I'll start it just now.
Ryan, I've got a few questions. They're not.
I'll put another one.
There's no controversy. It's based on the fact that we're nearing.
Elana, the people are already joining, hey?
Okay. Okay. Sure. Hi, everyone.
Give it another 30 seconds and I'll start it. Hi, everybody. Thank you so much for joining our webinar. The situation is exceptionally serious, as we all know. People need to be updated. People need to be informed. So, Dr. Noach, I want to thank you for making the time. And Elana, there is nobody better to interview than you. And I want to thank you for doing this every time I ask you. So without any delay, I'm going to pass over to you, and I look forward to hearing. Thank you.
Rabbi Masinta, thank you so much. And thanks for everyone that's joining us this evening. When the mailer went out, I could tell that there's a lot of interest in tonight's conversation. Doctor, welcome back to you. Ryan Noach is joining us, CEO of Discovery Health. A very busy time and a day for you. So I want to thank you for taking the time to answer our questions tonight and also to share your knowledge with us. Now, the last time that we chatted, we shared predictions, and by no means are any of us fortune tellers, but you were right. And there was a second wave and there is a third wave. We also talked about a possible fourth wave, but an update on the dynamics of the third wave, a vague question, but I think based on the fact that we've all had busy days, me being in media and you being with a medical scheme and in the medical profession, I can tell that we've both had very busy days. What's an update from your side on the third wave?
Thanks so much, Elana. Thank you, Rabbi Masinta, and it's great to be back with you again. Elana, I've prepared a presentation, which I, with your permission, will run through. And then perhaps we can have some Q&A after that. The presentation, I think, is filled with the update you seek. Can I go ahead and share my screen?
That would be great. Thanks so much.
Can you see that clearly?
All right, so it says that you are sharing your screen, and there we go. Okay, you're live. Thanks.
Okay, well, good evening, everyone. Great to be with you. I'm hoping you're dialing in safely from your homes, as I am. I'm working from home at the moment. Unfortunately, there are some healthcare workers who can't just stay home. They're out there in the front line, exposed to this disease and its virulence at this time. And I want to just start by paying tribute to them as heroes in the front line, and to thanking them, and specifically all the vaccination staff that are out there exposed every day, but doing what needs to be done in the context of this third wave. We're at a very difficult time as a country and as a world, but particularly in the country. It's a somber time. The rabbi, in a discussion with him the other day, said to me, it's just dreadful what's going on. He's spending every day at West Park at the cemetery. You know, one has to just spare a thought for families, family units, loved ones that are going through this very difficult time. Sorry to start on that somber note, but let me dive into it and try and share some information. Education is power, and human behavior really has a direct impact on person-to-person spread. And I hope through sharing information, we can also impact the spread of the disease. I'll talk a little bit about the third wave. The rabbi specifically asked me to touch on the vaccination rollout, and I know, Elana, you've got some questions around that, and maybe share some information with you from our data on long COVID, which is turning out to be frightening, and perhaps the second order effect that we're facing. As I said when we met last time, Elana, I spoke about the likelihood of another wave. We think of the emergence of another wave in a formulaic way, as a product of the immunity of the underlying population, the amount of interpersonal contact, And the severity of the individual response is really determined by an individual or population level risk index. So just unpacking those, immunity is a factor of course, how many people have already had the infection. And as I'll show you later in the presentation, we think that the penetration or the prevalence of infection across South Africa is actually quite high. Probably about 62% of the country has already been infected with COVID-19 at some point. And we will reach a point, we hope, of herd immunity where the occurrence of waves become less likely. So the first part of the formula is to say that a wave is a function of 1 minus the underlying immunity. The one caveat there is that we are seeing reinfections, and I'll share some reinfection data with you along the way. The second issue, of course, is our human behavior. This virus can only spread through people being close to each other, through a lack of social distancing, through people not wearing masks. That is how it spreads. It spreads by aerosol spread. There are micro droplets in the air. And so if we double mask, if we maintain social distance and we avoid interpersonal contact at risky times like this, we will definitely flatten the wave and abate the spread. And this goes without saying. And then thirdly, we've been able to show that there is a certain resilience to COVID-19 in young, healthy people. And now that we understand who's at risk, our priority should be to protect those that are most at risk through vaccinating them first, and of course, ensuring that they're able to maintain all the behavioral precautions. So that's how we think about the likelihood of a wave. Of course, as everybody knows, we are in the midst of a third wave now. But what characterizes this wave differently to the previous waves that you see on this chart is it's really characterized by this very steep climb of infections in Gauteng, towering above all the other provinces and really leading the country's wave. You can see the South African wave indicated in yellow as the next largest wave, but Gauteng is currently representing about 60% or more of the total national infections. And so this wave is really driven by what's happening in Gauteng. As I'll show you in later charts, the good news is that some of the smaller provinces already peaked and are coming down the other side of the wave. That bodes well for us to hopefully reach a peak at some stage soon here in Gauteng, where I'm talking to you from. So unfortunately, the deaths tend to follow about 2 weeks behind the infections. So on the left-hand side of this chart, I'm showing you the infections with that steep Gauteng peak there. On the right-hand side, I'm showing you the deaths. And I mean, it's quite obvious to see that we're still rapidly on the ascent in terms of the number of deaths per day. We're expecting over the next two weeks that the number of deaths per day increase quite rapidly to reach the same sort of peaks that you're seeing of infections on the left, and probably to exceed the number of deaths that you can see highlighted there in the second wave. It is a misnomer to believe the published number of COVID-related deaths, which I think now is around 55 or 60,000 deaths. We believe that the deaths are much greater than that. And if you look at the South African Medical Research Council's excess natural deaths report, which tracks the normal mortality rate in the country and can measure, and it's directly linked to these waves, when there are excess deaths, they're predicting that excess natural deaths in this period are standing at about 175,000 deaths. If you just assume that 90% of those relate to COVID, we're probably in the order of 150 to 160,000 COVID-related deaths in our country in the period, making our country one of the worst affected in the world, unfortunately. I think this is commonly known by everyone, but I did want to share Discovery Health's data. This is our own data. This is data that I've curated and that I can vouch for. And I can tell you that it shows unequivocally that people of older age and those living with multiple chronic diseases, age shown on the left-hand chart, chronic diseases by the number of chronic diseases on the right-hand chart, you can see firstly an exponential relationship between severe illness measured by an admission to hospital and age, with people over the age of 70 being 50% likely of being admitted to hospital if the COVID-19 infection. So 1 out of 2 people over 70 who catches COVID-19, that's a Discovery Health member, they'll end up in hospital. And then you can see on the chronic disease, there's a linear relationship between the number of chronic diseases you have and your likelihood of being admitted to hospital. So these are the people at risk. The usefulness of understanding this is we know where there's weakness and resilience. These are the people we must vaccinate first. These are the people we must keep safe first. Just moving from infection counts to morbidity, as we call it, or the number of hospital admissions. What I'm showing you here is the Discovery Health members admitted to hospital over the duration of COVID, dating back to March 2020 until the 30th of June, 2 days ago. And what you can see is that wave 3's admissions on the right-hand side have reached almost the same level as the peak of wave 2. The frightening thing being that we haven't quite peaked yet in wave 3. So it seems inevitable that there will be more people admitted to hospital in wave 3 than there were in wave 2. And you know, we're really all, I think, at family level feeling the brunt of this. As we sit here today, 3,200 odd Discovery members admitted to hospital, about 800 in ICU and about 400 on ventilators. That is a massive burden of disease. And this is a dreadful disease with people struggling to breathe. People of all ages. It's not only the elderly, as I've shown you, they're more likely to land up in hospital, but it is people of all ages, unfortunately. A lot has been spoken about this reproductive factor, or the R0 factor. I think people now have become experts on pandemics and they understand the reproductive factor. But really, to make it simple, the reproductive factor is the number of people that catch an infection from an index case. So a reproduction factor of 1 means that if I caught the disease, I'm likely to give it to one other person. A reproduction factor of 2 means that if I've caught the disease, I'm likely to give it to 2 people. Anything above 1 leads to an exponential growth in infections. It creates an exponential curve of spread. So wherever you see a number above 1, it's worrying. So what I'm showing on this chart is the reproduction factor for all 9 provinces across the country. And sadly, as you can see from yesterday or the day before, only 1 province has a reproduction factor below 1. That's the Northern Cape on the bottom right corner, where the reproduction factor is basically 0.8, which means that the number of new daily infections is decreasing. They're coming down the hill of the 3rd wave. They had a worse 3rd wave than the 2nd wave, and they're over it. The Free State's reproduction factor is dropping quickly, and looks like the Free State has peaked and is also coming down the other side. Unfortunately, the rest of the provinces, it's not the case. The wave is still growing. I think what we're particularly worried about in yellow is Limpopo and KwaZulu-Natal. KZN is coming off a very low base. They've got a very low infection count. So even though they've got a high reproduction factor and it's growing rapidly day on day, we're still seeing in absolute terms very small numbers in KwaZulu-Natal. And in Limpopo, a massively high reproductive factor. I think we're in for a very bad wave there. I want to highlight Gauteng. The reproduction factor in Gauteng, there you see there is 1.3. It's come right down from 1.5. This is an early sign, we think, that we're starting to near the peak in Gauteng. It's not true for the Western Cape, where the reproduction factor is still on the way up and is now at 1.32, heading towards 1.4. We think the Western Cape may well be at risk of heading into a severe 3rd wave now, just behind Gauteng. So I hope the reproduction factors as they stand today are clear. Why these are so relevant is explained in this actuarial analysis prepared by the Discovery Health actuarial team. In the blue, what you see here is an estimate of the population percentage that's been infected by COVID since the start of the epidemic in South Africa until the 17th of May. So taking into account all infections over the whole of COVID until the 17th of May, as I said earlier, we think 62% of South Africa has had an infection. But if you look across the provinces, quite varying levels of infections. Now, remember that wave equation I showed you on the first slide? I spoke about immunity, underlying immunity. Well, if you look at the Eastern Cape, for example, we estimate from our calculation that more than 90% of people in the Eastern Cape have already had a COVID-19 infection. That means, in our opinion, that there's a high level of underlying immunity in the Eastern Cape already. We think that predisposes the Eastern Cape to a very mild 3rd wave. We don't think they'll have a severe 3rd wave. We may well be wrong. This disease is full of surprises. And I'm going to contradict myself on an upcoming slide when I talk to you about reinfections, which break this immunity model. But assuming that the immunity is lasting, compare the Eastern Cape to Gauteng, which has an infection prevalence of 43%, one of the lowest in the entire country. The only lower one is the Northwest. So it looks like Gauteng is at risk of a massive third wave, and we're living through that. What the team then did, the actuarial team, is they calculated in green what the reproduction rate would need to be in order to cause massive spread, massive uncontrolled spread. You can see that in Gauteng, they estimated 1.8, but in the Eastern Cape, they estimate over 11. So it gives you a sense of how fast the disease needs to be spreading to overcome the underlying immunity. And when you compare that to the actual reproduction rates, you can see that in Gauteng, we got to 1.6. So we reached that point of a severe wave, whereas in the Eastern Cape, they're miles away, in our view, from triggering a third wave. We think they'll have a third wave, but we think it will be mild. Look particularly at the Western Cape, which I'm worried about as I talk to you now. The Western Cape has an underlying infection prevalence of 50%. And on the date that I prepared this analysis with the actuaries, its reproduction rate was 1.6. That was on the 7th of June, nearing the 2 mark, which was the threshold for uncontrolled spread. We're worried that the Western Cape is most at risk for another imminent wave. So what I'm showing you here is a chart that predicts reinfections. Let me tell you that, unfortunately, we've had more than 2,000 Discovery Health members who have tested positive for COVID-19 more than once. We've got 5 members that have tested positive 3 times and 2,000 that have tested positive twice. This undermines that whole equation that I showed you up front, because if the immunity doesn't truly protect, and if reinfections can occur, then we're all susceptible for waves as and when they come along. I think the comforting part is our analysis demonstrated in the charts above show that people who have had one COVID-19 infection before are at a 27% risk of catching a second COVID-19 infection relative to the rest of the population. So you're about 1/3 as likely as somebody who's never had COVID-19 of being reinfected. So the immunity does confer some protection, probably 2/3 protection relative to the rest of the population. And I hope that's clear. It means, from a behavioral point of view, if there's a call to action and a take-home message, that we really need to ask everybody, whether you've been infected previously or not, to stay safe, to wear a mask, and to social distance. What this chart shows you, ignore all the numbers on the left, is it shows you our projections on the right-hand side of what we believed the third wave would look like for the country. Now, this is the country's wave, not Gauteng's wave. And you can see that there's 6 charts. 3 of them, the top 3 on the legend, were without vaccines, and the bottom 3 was assuming South Africa was vaccinated by this point in time. We made this prediction ages ago, around about February, I think it was, this year. So I'm showing you the February prediction to tell you that currently where we're tracking is, unfortunately, on this blue chart of the highest and worst wave that we forecast, including the fact that an inadequate number of people are vaccinated, only 5%. So an inadequate number of people have been vaccinated. So for us, this is our worst case scenario on our actuarial projection. And sadly, the deaths are tracking that blue line almost exactly as we sit today. So let me move along quite quickly then through vaccination. I don't want to repeat things you're hearing all the time in the media, so I'm going to go quite quickly and stick to the key messages. In this phase of vaccination, we're seeking to vaccinate 6 million people, as you see in blue on the chart on the left-hand side. That includes 5.5 million people over the age of 60 and 500,000 healthcare workers. And what I'm showing you on the right-hand side in the block is that we've got sufficient vaccine being delivered to the country to meet the requirements of vaccinating these 6 million people. And now we've opened to the 50-year-olds plus. It's supposed to open on the 15th of July, but it effectively opened today. And so we have got sufficient vaccine in order to meet these requirements. Going forward, I'm showing you in gray the J&J deliveries and in blue the Pfizer deliveries. There is sufficient vaccine to vaccinate the entire population over the age of 18 years. So the message on this slide is that we've started with priority groups. There's enough supply to cover everyone. My personal wish is that it would all be coming in quicker, but given the global demand and the constraints on global supply of vaccine, this is as fast as we can get it. And we're hoping that by the end of the year, we've completed the majority of the vaccination campaign for those people over 18. So as at the 30th of June, the country had vaccinated just under 3 million people. In Discovery Health, we'd vaccinated over 140,000 of our members, which represents 5.5% of our total membership. But importantly, about 16%, in fact, it's higher now. I think it's 20% of the phase 2 targeted group. What's important, and this is critical to tell you and emphasize, is that we are only administering about 120,000 vaccines per day as a country at the moment, but we have enough supply to do about 150,000 a day. And so the real plea on this page is to say, we've got to increase the amount of vaccination being done. And I think opening up to the over 50s, as the country has done, will hopefully accelerate and speed up this vaccination campaign. This is a very complicated chart, and I apologize for the complexity. Just let your eyes be drawn to this phase 2A column here in the center of the screen, where I show 10 million people that we're aiming to vaccinate. Those 10 million people include the over 50s, the over 60s, and the healthcare workers. Unfortunately, of those 10 million people, only 25% of the 8 million that have no medical insurance have registered on the EVDS system to date. So in light blue, you can see 8 million who don't have medical insurance, 2 million who do. You can see 25% of the 8 million, 2 million are registered on EVDS. In the insured category, it's 700,000, which is 35%. It's a bit misleading because included in this number is the plus 50-year-olds, and we've only just opened up for that now. And so I'm expecting these numbers to jump materially over the next few days. But as we sit here today, this is what the numbers look like. If you then track from who's registered, who's been vaccinated, of the 2 million registered, 55% were vaccinated, and of the 700,000 insured that are registered, about 80% have been vaccinated to date. So I hope that gives you a sense of where we are in the vaccination trajectory. In the interest of time, I'm going to move along. Just to say that we are vaccinating or aiming to vaccinate 25,000 people per day through Discovery sites. We're opening additional mass vaccination sites over the next few days. We're opening one at the International Convention Center in Cape Town that will do 5,000 a day next week, Tuesday. And we're opening one in KZN the following week. So we'll have these 4 mass vaccination sites, our offices, Gallagher Estate, Cape Town and KZN, plus some smaller sites, so that we can contribute our piece to the vaccination program. Just interesting for you to know that the people we're vaccinating at the Discovery sites are from all medical schemes. What you can see on the top right of the slide is a breakdown of who we're vaccinating at our own sites. 60% are on the Discovery medical scheme, which is roughly its market share. The balance are on other medical schemes or uninsured. And if we look at where our members are being vaccinated, shown on the bottom right-hand side of this chart, you can see that 28% of our vaccinations for Discovery members have been done at Dischem, and 27% have been done at our head office in Sandton at one Discovery place, and the rest of the market follows. We have created a booking platform. For those of our members that are listening to me now, I would invite you please to go onto the Discovery website, register on the booking platform, and we will allow you then, when you're eligible, and for the over 50s, you'll be able to do this from tomorrow morning. You can book for your vaccination. You may even get a booking the same day if there's space available, and then you can arrive to be vaccinated. This is an important point, and I'm anticipating questions here, Elana. Everybody's asking me, can I walk in and arrive and just be vaccinated? The answer is no. And the reason we don't want to do that is twofold. The one is we end up overwhelmed and we're at risk of a super spreader event at our building. People are arriving in mass, a deluge of people. And so we just can't accommodate walk-ins on that basis. And the second is that it's most inconvenient because people come, stand in a queue, and then get sent home or end up queuing for 4 to 5 hours. We don't want that happening at our sites. So we ask you please to use our platform, book, and then when you arrive for your booking, at least you'll know in an hour or two your vaccination is done. The good news is that if we look at the global evidence, vaccines work, and it seems completely unequivocal. Even in the context of this Delta wave and the variant that we're dealing with now, it seems unequivocal that vaccines work. If you look at this chart, on the top of the chart, I'm showing new infections in Israel, the UK, US, and Chile. And on the bottom of the chart, I'm showing deaths in those same 4 countries. Look at the first 3 countries, Israel, UK, and US. What you see on the chart is the blue line that ascends steeply. That line relates to the number of vaccines done. And you can see that they've done well to vaccinate a large portion of their population quickly. Then you look at the green line, which shows the number of infections, and the infections have dropped down to almost 0 as a result. If you look at the deaths have done the same, particularly in Israel and the UK, where their vaccination levels are very high at the moment. They're having days with no deaths whatsoever. So the protection against mortality in this disease looks astoundingly good. The outlier on these charts is Chile. Chile looks different. They've done an aggressive vaccination campaign, but they've had another wave, a second and third wave of COVID that you can see on the top. And they've had some deaths, fewer, but some deaths that you can see on the bottom. And the difference in Chile is that they used, unfortunately, the Chinese vaccine. And the Sinovac vaccine, which they used in Chile, appears on the face of it, on this data, to be less effective than the Pfizer, Moderna, AstraZeneca, J&J vaccines that are used in the other countries on these charts. And that does seem to be the difference. We hope that's the difference. And we hope that it's not about a different variant or the like. I think just to give another data point, a very interesting chart from Alberta in Canada, from the Alberta health system. What this chart shows you is a map of the people currently in ICU for COVID-19 in Alberta, Canada. And you can see that they've had a pretty serious wave where they've had 160 people in ICU in Alberta all at the same time. In red is the unvaccinated population. In the other colors is the vaccinated population. And in purple, the dark purple, is the fully vaccinated population. And the good news about this chart is that you can barely see the purple on this chart. Really what it's telling you is that fully vaccinated people very infrequently, if ever, land up in ICU as a result of COVID-19. That's what the global evidence is showing. There should be a reassuring, and it really, I think, should encourage you, please, to get vaccinated. Everybody should get vaccinated when it's your chance. The good news about the vaccines as well is that whichever variant you look at, including the Delta variant that we're dealing with at the moment, the vaccines seem to be effective. Specifically on the Delta variant, AstraZeneca and both the Pfizer and Moderna vaccines have been tested. For South Africa, the J&J vaccine has not yet been tested fully against the Delta variant, but it follows very similar dynamics and is structurally a very similar vaccine to the AstraZeneca vaccine. And there's every reason to believe it will protect against severe disease. Let me share an anecdote on this, which is important at this point in time. As you know, all the healthcare workers in the country were vaccinated with Johnson & Johnson through the Sisonke trial. What we're hearing anecdotally from the hospital groups, from the CEOs of Netcare, Mediclinic, and Life Healthcare, is that their experience for their employees through this third wave is dramatically different to all the other waves in COVID experience. Firstly, they psychologically feel much more resilient, and one can understand that they feel stronger because they're vaccinated. So psychologically, it's helped. But secondly, and importantly, fewer of them are catching COVID-19. And most importantly, they've had almost zero healthcare workers admitted to hospital during this third wave. That is good news. That is good news. So we've got a real life experiment going on with the healthcare workers, and the Johnson & Johnson vaccine seems to be protecting them from severe illness. This is an interesting chart that's emerged from CRISP, where Prof. Tulio de Oliveira in KZN at the University of KZN and his team do genotyping or genetic analysis of COVID-19 around the country. And what they're seeing in the genotyping is this rapid emergence, almost explosive and frightening emergence of the Delta variant. The Delta variant is colored in green here. The Beta variant, which used to be called the South African variant, right, incorrectly named, that Beta variant is in blue. And what you can see here is that until roughly the 7th of June, most of the COVID infections in the country were the Beta variant. What suddenly happened between the 7th of June and the 14th of June, a week later, is that more than 60% of the infections in the country became related to the Delta variant. This is probably the explanation for why we're having this third wave. The Delta variant is much more transmissible. Unfortunately, it is highly, highly transmissible. They say that it's got a 30 to 50% higher chance of transmission. In other words, you're twice as likely to catch it. And there's an anecdote emerging from New South Wales, where they're in lockdown in Sydney, Australia at the moment, about how the Delta variant spread. It was an Australian guy who was a driver who'd been to the airport, who caught it from aircrew, who went into a shopping center, and they track him on CCTV. And as he walks through the shopping center, he hovers around the tills in the retail center and around the aisles. And they can demonstrate through contact tracing down to individual level that the people that were standing near him, just standing nearby him, looking at the same shelves as him, they caught the Delta variant from him. They then went off to their families, and there was family spread, and a couple of them went off to parties, and there was spread at parties. And before they know it, they had a COVID outbreak in Sydney, and they went into lockdown. So this Delta variant is dangerous in that it's highly transmissible. The good news is that we're seeing no difference in admission rates and no difference in mortality rates on the Delta variant. That's our experience to date. And so as far as we can see in the data so far, that it's not more lethal, and it doesn't necessarily cause more hospital admissions, but it most certainly is more contagious. And hence me being like a broken record and reminding you and everybody that we really do need to adopt all the social distancing precautions that we absolutely can. So just moving on to the signs of effectiveness of the vaccine in our own data. This is exciting because this is people like you and me who are Discovery Health members. They've been vaccinated by us, many of them at the Discovery site. And what we're seeing in this cohort of people is very positive early signs that the vaccine is having a positive effect on the population. Firstly, what you can see is on the left-hand chart, you can see the mean number of infections, the cumulative incidence of infections in the vaccinated group in blue and in the non-vaccinated group in green. And if you look carefully at the graph, you can see that roughly at day 21, after the first dose of the Pfizer vaccine, there's an inflection point in that blue line, and it starts separating from the green line. And so what this is telling us is that from 21 days after your first dose, you seem to be less likely, less prone to catching COVID-19 relative to the unvaccinated population. That's our own data and our own people. So that's good news. And we expect that gap to widen dramatically after the second dose, almost to double, we would think. And then in terms of endorsing that, if you look at comparing the vaccinated people to what we call clinical twins. So we take people who are vaccinated, a 65-year-old woman with diabetes and hypertension who's vaccinated, and we match that person to somebody like them in the data, a 65-year-old person living in the same municipal district with the same chronic diseases, who we believe has the same COVID-19 exposure. And when we do that, what we see very clearly, if you look at the median, is that within the 14 to 20-day period after the first dose, there's a 12% relative reduction in risk of catching COVID-19. But from 21 days onwards, there's almost a 50% relative reduction in risk from catching COVID-19 relative to people just like you, but who are unvaccinated. So I hope this is reassuring to you that we're seeing early signs that the vaccine is working. I apologize about this busy slide. I hate busy slides like this, but I'll draw your attention to the bottom chart. I wonder if I can actually create a pointer here. Let me see. Can you see my pointer now? On the bottom chart, have a look at these numbers here. In people with less than 14 days since vaccination, 1,200 of them caught COVID-19, Discovery members. In those with more than 14 days post-vaccination, 1,000 of them caught COVID-19. Of those 1,000, 217 landed up in hospital. But of the 1,200, 350 landed up in hospital. Have a look now at the deaths. For the vaccinated cohort who had a single dose, the first dose of Pfizer, more than 14 days ago, we've had only 5 deaths. For the vaccinated cohort who had their vaccine less than 14 days ago, we've had 35 deaths. So what we're starting to see just from the first dose of the Pfizer vaccine is a gap in infections, morbidity, and mortality for Discovery Health members who are vaccinated. If there's one message emerging from this, it's to be patient, to remain socially distanced, and to stay home until you're fully vaccinated. And fully vaccinated means 1 dose of Johnson & Johnson and 30 days have elapsed, or 2 doses of Pfizer and 30 days have elapsed. That's what fully vaccinated means. The other bit of news about the vaccines is that the side effects seem to be minimal and manageable. So the Sisonke trial under Prof. Glenda Gray has published a paper, which was published in the South African Medical Journal, of the side effects of 300,000 people who were vaccinated with the Johnson & Johnson vaccine under Sisonke. About 2% of them faced side effects, and 80% of the 2% had very mild to moderate side effects. Only one presented with a severe allergic reaction, and that person was treated and managed and is fine and is recovered from the allergic reaction. 5 people presented with a clot, a thrombosis. You'll remember all the publicity around clots. Well, these 5 people were all at very high risk for clots. Some of them probably would have had a clot in the period anyway. Who knows? They may or may not have. But all of them have recovered reasonably well from those clots. And we had no cases at all of this thhe syndrome, or vaccine-induced thrombotic thrombocytopenia, which is a coagulation disorder that can result from the Johnson & Johnson vaccine. When we look at our own data, we looked at about 110,000 of our members who'd been vaccinated. These were the claims that happened in the immediate period after vaccination, 7 days after the vaccination. And you can see a very small proportion of the members actually had any claims, and the majority of them were over-the-counter claims for over-the-counter pain medicines, bronchospasm medicines, and the like. The vast majority of this was completely minor. We had 1 member who was admitted to hospital post a Pfizer shot. That member did have an allergic reaction and has been discharged and is fine now. One other positive angle, and I'm trying to share positive news on vaccination because it is a positive story, is that our Discovery Health policy unit run by Professor Roseanne Harris has done an economic analysis of the benefit of vaccinating South Africans. And what they've found is that there's somewhere between 11 and a 20 times return on investment for the economy of vaccinating all South Africans. In other words, in simple speak, for every rand we spend on vaccination in South Africa, we get about 11 to 20 rand back as a dividend from the economy in the form of enhanced gross domestic product as a result of restoring productivity and livelihood to people whose livelihoods are currently impacted by the lockdown and COVID-19. This was quite similar to the analysis that you see on the left-hand side, which was done by the World Economic Forum, that showed a 12 times return on investment for vaccinating the world. So just a couple of points before I get to the last section and move quite quickly through that. The first is that it seems very likely that booster shots are going to be required going forward. Because of the emergence of variants, it seems likely. There was an article in the New York Times following a clinical journal article last week, which said that the immunity from Pfizer and Moderna vaccination, the mRNA vaccines, is likely to be long-lasting. Nobody's prepared to put a number on what long-lasting means, but there are very good signs that the antibodies from the mRNA vaccine seem to endure. It does seem likely on the adenovirus vector vaccines, which is the Johnson & Johnson and the AstraZeneca vaccine, that booster doses will be needed. And I think those protocols will be updated soon, in my view. The other good news is that children will be eligible for vaccination soon. It has been proven to be safe for people between the ages of 12 and 18 years. And I'm sure in due course, when our country has vaccinated all adults, we'll get to vaccinate kids as well. And the third very interesting bit of evidence that's emerging is that at city level, when you look at a confined city space, there are very positive stories about herd immunity developing within cities. San Francisco is a good story, but the one that was really interesting to me is the one published in The Economist last week, which you see on the bottom of the chart here, about this town in Brazil. The name of the town is Serrana. I typed it into the notes there. What they did in this town was they did an experiment. I think you probably all know that Brazil is severely impacted by COVID-19 and going through another severe wave. But they took this one town, they closed the borders to the town, and they vaccinated the whole population of the small town. And guess what? They are mask-free, lockdown-free, social distance-free, infection-free, and admission-free. There's just no COVID-19 related illness in the small town. So this island in the middle of Brazil demonstrates how effective vaccination can be at a geographic or a city level. Sorry, a sip of water before I spit out my vocal cords here. So just moving on very quickly to the long-term impact of COVID and to talk about long COVID specifically. Unfortunately, it's our view that the second order impacts, the knock-on effects of COVID, once we've vaccinated everyone and COVID is under control, may be just as severe as COVID itself. And so I think when this pandemic ends, firstly, I think we're going to be faced with a second pandemic of mental health illness. We're also going to find that all the people living with chronic illness who've avoided going to hospitals and seeing their doctors in this period, they may develop severe illness. We're also going to have a resurgence of cancer diagnoses because we've seen that the routine cancer screening, pap smears, mammograms, that's all stopped. People just aren't going to their doctors for that. And so we're registering about 40% less cancers now than we typically do. That doesn't mean that people aren't getting cancer. That means that people are living with cancer and that it's undiagnosed. So I think we're going to have that phenomenon. And importantly, I think, unfortunately, we also are going to live with this phenomenon of long COVID. Let me describe to you in health insurance terms what long COVID looks like. The chart on the right-hand side plots health insurance costs, claim costs, the costs that we pay out for Discovery Health members' health claims against time on the x-axis. So health insurance cost on the y-axis and time on the x-axis. If you start with a red chart, what that red chart shows you is somebody like me who's never had COVID-19 through the period. And what it shows you through that period is that their costs were at the index point of 1 until the COVID-19 wave started, when their costs decreased. And that's because people stopped going to doctors, stopped going to hospitals, and their health-seeking behavior changed. And their costs have remained below 1 all along because we've never recovered back to the normal functioning of the healthcare system. So that's a non-COVID person. What about somebody who's been infected with COVID once before? That's in the blue chart. This person is infected with COVID once. Their healthcare costs go up as they're treated for COVID. They come down afterwards. Importantly, take note that their costs remain slightly above the baseline. And that for you is the first evidence of long COVID. It's showing you that a proportion of the people who develop COVID and have an acute episode of COVID where they're needing claims to be paid, some of them, their claims never disappear afterwards. They are living with enduring symptoms and disease after COVID. Yet when they started before the COVID infection, they looked like the red group. They looked like everyone else. So that's worrying. And then the last chart shows you people who have had 2 COVID infections. Remember, I told you we've got 2,000 members who've been infected twice. Now, what's interesting about those people is they start off with higher cost levels, which means that they're living with some severe illness or disease beforehand. So that's the first interesting insight, is that you are more prone to a reinfection if you are living with a healthcare problem in the first place. They then catch COVID, but look what happens to their costs afterwards. Their costs never return anywhere near the baseline. And then they catch a second infection of COVID that you see on the right-hand side here. So what we know about the reinfection group is that they're probably sick, maybe diagnosed or undiagnosed to start off with. They're definitely claiming from the healthcare system. And after the COVID-19 infection, they never get completely better before they land up catching a second COVID-19 infection. These are scary insights, scary for me as a doctor and as a citizen of the country, because I think we're dealing with a disease here with some long-term ramifications that we don't fully yet understand. What we've shown in our data, this is Discovery Health member data, but it's substantiated by global evidence that you see in these articles on the right-hand side. But what we see in Discovery Health's data is that you have a 2.75 higher risk, 2.75 times higher risk of developing diabetes after a COVID-19 diagnosis. So in people who are not diabetic and were diagnosed with COVID-19, you have a higher risk of being diagnosed with diabetes afterwards. Now, I would argue that they were probably living with some impaired glucose tolerance or underlying poor glycemic control before the COVID infection, and COVID effectively unmasked that. But what's indisputable is that we're diagnosing diabetes in a high proportion of post-COVID infected individuals. The same is true for cardiac disease, just a lower risk, 1.5 times. 1.5 times increased chance of being diagnosed with a cardiac condition after a COVID infection. The rest of healthcare, as I said to you earlier, is down. You can look at all the other metrics. I've got 2 slides of them for you, and I'm not going to go through the detail. I'm going to wrap up now. But just to say, whether it's cardiacs, whether it's gastro around scopes, whether it's ENT around tonsils and adenoids, whether it's orthopedics around spinal procedures or eyes, whichever it is, whatever you look at, the rest of healthcare is suppressed at the moment. And that while there's some wastage that we've got rid of, which is a good thing, the bad news is that there's some disease that's not being treated. And that's equally large problem as far as I'm concerned. So Elana, it's a long-winded answer to your question. You asked me for an update on COVID, and I've given it to you letter and verse. I hope that fills you in, and I'm happy to take a couple of questions. It's 8:15, and I think we've got a few minutes remaining.
First of all, Ryan, thank you so much for that stunning presentation. I mean, a lot of the comments that are coming through are saying, thank you for the clarity. You've also answered some of the questions. So, I mean, some of them I'm going to go through just so that we know what was asked. I'm going to highlight a few. The others, I think we can do for quick fire. Someone had a question right at the beginning. I think it was Josi that asked a question. He says, vaccinations are critical for flu. Would one have to prioritize the vulnerable first next year, or do we continue to roll out with the rest of the population? I saw an article that talked about how people with comorbidities won't be a priority ever. So just a quick response from you on that.
Yeah, 2 important questions. On the flu vaccine, it's essential. I have it every year. I give it to my family and my parents every year, and I would advocate you have it. Unfortunately, for 2021, the flu season is largely gone, and it's too late to be vaccinated now. So keep that in mind for around about April next year. On the comorbidities, Elana, in my view, and I think this is a strong Discovery view, it's critical to vaccinate those people living with chronic illness first. The complexity is the following. Other countries have tried it because it makes rational sense. And what happened in other countries is it became almost impossible to manage. They had people arriving at vaccination centers claiming to be living with a chronic illness. They couldn't prove it either way. The system ended up being completely abused. The rules were frivolous, and they ended up dropping those rules and just going with age segmentation. So in the absence of a central clinical record for the country, you can't easily apply that at a country level. From a Discovery Health perspective, we have a central clinical record for every member in Discovery Health. We know exactly who has got a chronic illness. We will do our very best to make sure that those people get vaccinated first. And we give a commitment to really try and do that. And the last comment on that question is in Israel, where they have a central clinical record for the whole country, they did vaccinate the people with chronic illness first after they did the elderly.
Just a medical scheme related question as well. There's a few asking, can people who have no medical aid book a vaccine at Discovery?
The Department of Health has asked us not to do that because we do charge them. It's a minimal charge. It's 86 Rand, but we do charge them 86 Rand when we vaccinate the uninsured. And so the Department of Health has said to us, please allow uninsured to go to the public sites and the insured come to the private sites. The truth of it is, Elana, and I'm saying this openly and honestly, we vaccinate whoever comes as long as they're in the eligible age group. And that's what we've been doing to date. Not officially, no. But if you have a domestic who, is part of your family, for example, and, is considered almost a family member and you're going to get vaccinated and you want to bring them along, we'll do our best to try and help.
Okay, you've answered that one. Stephen says, should one have both the Johnson & Johnson's and Pfizer vaccines? A few have asked also, if I've had the Johnson & Johnson, should I get vaccinated with the Pfizer vaccine as well? The others have called it a top-up after the Johnson & Johnson's vaccine.
Yes.
Okay.
This has actually been quite well studied, and there was a paper that emerged last week about mixing the AstraZeneca vaccine with the Pfizer vaccine. And AstraZeneca, like Johnson & Johnson, is an adenovirus vector vaccine. So it's a very similar vaccine to the J&J vaccine structurally. That paper showed in the AstraZeneca case, it was done in the UK, that there is a material benefit of having a single dose of Pfizer after having had vaccination with both AstraZeneca doses. So I think, the world's perspective on this. I'm not a vaccinologist and I'm not a virologist. So actually, I'm not the right person to answer the question, and I must caveat that. But certainly what I'm reading and what the experts are telling us, and I had a conversation with Barry Shube, who is an expert on this recently, is that it's becoming advisable to have a single Pfizer injection or Moderna injection after being vaccinated with one of the adenovirus vector vaccines. I must qualify that in South Africa at the moment, the Department of Health and the EVDS system do not allow it. Okay. So you can't get it today. In fairness, I actually think that's probably right, because the truth is you're fully vaccinated after one dose of J&J. You're protected against severe disease. Let's vaccinate the unvaccinated first before we start giving boosters to the vaccinated.
Okay.
But that's the Department of Health's position on it today.
You talked about 2,000 members earlier and reinfections. There's been a few questions around how the immunity works. So if I've had my vaccine, how soon after that can I get COVID?
Well, as I showed you on those charts, the inflection point seems to be 21 days after the first dose of the Pfizer vaccine, that there starts to be a gap developing between the vaccinated and the unvaccinated. But I want to caveat that, and this is probably the most important message of them all. When you're vaccinated, act as if you're unvaccinated. You may be a carrier and you may infect others. You may be asymptomatic. You also stand some personal risk. The vaccines, are not foolproof. It doesn't matter whether you're vaccinated or not. Don't behave differently. Protect yourself and protect others.
There's a question here from Mike. He says there is a concern amongst younger adults that are having the vaccine. Could it affect fertility? Is it true?
It's totally untrue. There's absolutely no evidence to substantiate that. It's very unfortunate fake information that's being disseminated.
Okay, just another scheme question, and this is from one of our platforms as well. It says Discovery has asked people to register on their site, so for the EVDS, and then they get this SMS. So if they haven't gotten the SMS, should they go directly to the site or should they wait?
There's no harm in going to EVDS as well as coming to our site. So my answer to that is do everything you can. But if you've been to our site and you've registered on our site, you will be able to book then on our platform, and we have a booking system so that you get a slot And then when you come, we will ensure that that you're registered on EVDS when you arrive.
Okay, there's quite a few questions coming through. I'm going to take a few more. Some questions about an update on the third wave. Ryan has done an entire presentation on this, so please log on to Chabad South Africa and have a look at the video from the beginning. We are recording this for Facebook and YouTube, so you'll be able to get the information on that. Also, travel bloggers said that some of the countries are reopening, like America. When can we start traveling again?
I really don't know the answer. We are providing SA Tourism some data to try and help them get us removed from the red list. I must be honest that if I was a health advisor to any foreign government at the moment, I would block the borders to South Africans now in the midst of the third wave, because it makes no sense to accept people from a country that's going through an explosion of COVID-19. I would hope that as soon as this third wave settles, and our vaccination levels improve, that at least the vaccinated should be able to travel freely. There's absolutely no reason why, after the third wave abates in South Africa, we should be blocked relative to any other country. No reason, no logical reason whatsoever. We are at Discovery developing a digital vaccine certificate. The Department of Health hasn't yet determined its policy, and the Department of Foreign Affairs or International Relations in South Africa has not developed its policy on how digital certification of vaccination will work. But the EU has developed a standard. America has developed a different standard. There are all sorts of queries coming up all over the world. There's no uniform approach. So what we are doing is we will issue a Discovery digital vaccination certificate to our members who we have proof of being vaccinated. And I'm hoping that in time we can ensure that's accepted for travel and for airlines and the like.
Okay, there's quite a few questions coming through about something that we've discussed right before the first wave already. Social distancing, washing hands, using sanitizers, masking, vaccinations. So we've had one from Anonymous, also from Professor Celine. Ryan Soliver, good to see you on the platform as well. He's saying the Delta variant is so transmissible. Are you still protected wearing a mask and sanitizing? I can tell you this as well, Doctor. I have had it. I had COVID a month ago, and we have been nowhere. I wear my mask. I broadcast from my home studio. And so Ryan has a point here. He's saying, what kind of protection are we offering ourselves against the Delta? What do we do? How much more can we protect ourselves against COVID?
You can only do what's possible, which is, in my view, at the moment, if you're going out, double mask. And remain outdoors and remain in well-ventilated spaces. And the reason I emphasize those three things as the most important is because there is strong evidence now to show that COVID-19 is spread through micro droplets. It's spread by aerosol. These are small little droplets of moisture that travel in the air. And if you're in a confined space, which we tend to do in winter because we're cold, particularly with other people close to you, sadly and unfortunately, like in a restaurant, particularly without your mask on, that is the most likely place that you're going to catch COVID-19. This aerosol spread is a big problem. They used to say 2 meters between people is enough. Well, if it's heavily aerosolized, somebody is singing, coughing, laughing, talking loudly like I'm doing now and spreading these droplets into the air, there's a good chance 2 meters may not be enough.
We need hope and reassurance. I was on air this morning and it was not even COVID related. And I had one of my listeners burst into tears, and I felt so sorry for this guy who has lost his business and who used to be the breadwinner of his family. And so we need reassurance, especially on the graph where you kind of show us that some of our provinces haven't peaked yet. Also how we had this discussion previously and how we predicted that there's a second and a third wave and that there will be another. What kind of reassurance can you give everyone who's watching and listening, from a scheme point of view, but also just in general, because you have the most knowledge about this?
Well, I have the most knowledge in this room, perhaps, but there's certainly far more knowledgeable people. I mean, there are many reasons to feel hopeful. The first is that the vast majority of people who contract COVID-19 are completely fine. the vast majority, they're completely fine. 80% of people who contract it are completely asymptomatic. They don't even know that they've got it. 80%. So the first reason to be optimistic is that in the main, this is a mild disease. And it's unfortunate that selects quite heavily against certain people. And then when it manifests, it can manifest severely. The second bit of optimism is that human behavior is what determines person-to-person contact. And so we should feel empowered and in control. Because actually, if we take the necessary precautions, you're not absolutely guaranteed you won't catch it, but you can reduce your chances exponentially of catching it without question. And that's a human behavioral thing. And the third and most important is that, thank goodness, there's been scientific innovation. I believe in scientific innovation. Vaccines have been developed in record time. They've been registered for emergency use. They work. We're seeing that in our very own data, never mind the rest of the world's data. They seem safe, which we're also seeing in our own data. We need to get everybody vaccinated as quickly as we can. It should be the norm. It should be the standard. And I see now in some of the Scandinavian countries, I was reading this morning, they're not going to allow people into shopping centers if you can't prove you're vaccinated. They're not going to allow people onto airplanes if you can't prove that you're vaccinated. So I think it's going to become the way of the world, that if you want to be an anti-vaxxer, you literally are going to have to live a very lonely life. But if you want to travel, if you want to socialize, if you want to mingle, if you want employment and to work in an office space, I think there's a good chance you're going to have to be vaccinated to do all of the above.
Ryan, this was really insightful, and we really thank you for your time. We know that you've got a lot of things to do in your busy schedule, but so what would a webinar like this be without a story? So I sat with Rabbi earlier and sat virtually, and we had a chat about this. And it talks about why did Noah send a dove out of the ark? And Noah was in his own lockdown. So there he was in his very high-tech boat, having an incredibly boring and dreadful time inside. And off he sent a dove to check whether the waters had subsided. And the dove returned because there was no dry land to set foot on. And so gently he brought back the dove inside. And it was just an indication and a confirmation of, first of all, your positivity around this, even though it is really dreadful, but also that even in a time of concern, of dreadfulness, and of disease and really difficult circumstances, there is nothing that stops us, all of us who are on this webinar, me and you and everyone who's watching and listening, from reaching out to others and still begging God and asking that bad times should end, and also for doing good. So Ryan, as much as you're a medical doctor and as much as you don't want to be called doctor and just Ryan, I can tell you this: I really appreciate you using your talent for good, for protecting so many people and sharing good and accurate information so that we can all stay knowledgeable and so that we can be a nation that will be calm and peaceful, and so that we won't panic, because all will be well.
Thank you, Elana. And if I can end also on one other positive note, and that's to tell a story of 100 years ago. 100 years ago, almost to the day, the world faced a global flu pandemic that killed many millions of people across the world. For 3 years, they lived in masks, they hid indoors, and the bodies developed natural immunity. And 3 years later, they emerged and life continued and resumed as normal. And our amazing biology managed to overcome the flu. And although every year we live with deaths as a result of flu, we live relatively normal lifestyles and have learned to protect each other from it. The same will be true for COVID-19. This too shall pass, as King David said. We do need to come together and behave responsibly as we live through it.
Doctor, thank you so much for your time. This recording will be live on Chabad South Africa's Facebook site. A big thank you to everyone that has made this possible, and especially to you, Doctor. A big thank you to Discovery as well. To everyone watching, my name's Elana. Have a good night.